disease on the left side, but it is at a earlier stage that is going to atrophy later on.
Okay. So I agree with you. So the right side, you can see that we've got a dysplastic appearing kidney. We don't have any corticomedullary differentiation. And these areas that are hypoechoic are the cystic lesions. So this is in keeping with the multicystic dysplastic kidney. On the left side, you mentioned that you've not got really good corticomedullary differentiation. And I just want to say that neonatal kidneys in particular, for the first couple of weeks of life, the cortex can appear quite echogenic. So this can actually be a normal finding in a neonatal kidney that where it might be, you're like, oh, is that corticomedullary differentiation reduced, having that echogenic cortex? But we do have some pelvic ileal dilatation, which can be a sign of obstruction or reflux. But I agree, this is an example of a multicystic dysplastic kidney on the right side. Can everyone see my arrow, by the way? Can you see my arrow? Yeah, perfect. So cystic renal disease in pediatric patients can be quite challenging because we've got 4 main types of cystic renal disease that we see. So the first type, as we saw in the previous case, is a case of a multicystic dysplastic kidney. And this is normally due to some in utero event that's affected the kidney. And what you get is that you get dysplasia, so you don't have any functioning renal tissue. And that damaged renal tissue is then replaced by multiple cysts. And over time, you can see some changes. So postnatally and as the child grows up, which I'll talk about in a bit, and I'll go into multicystic dysplastic kidneys a bit more later on. In terms of cystic diseases, sometimes we will just see kidneys that have a couple of cysts within them or have multiple cysts within them. And this is, and if we see that they have an obstructive uropathy, such as posterior urethral valves or a urethral or VUJ obstruction, because they've got backup of pressure, that can then cause damage to the renal parenchyma, and then they can get cystic change in the renal parenchyma secondary to that. So that's another form of cystic disease we see. And some people suggest that a multicystic dysplastic kidney is kind of on that spectrum, and we're seeing the end stage where the kidney is damaged beyond repair and we have no functioning renal tissue left. And then the 2 other types of cystic disease we can see in pediatric patients are autosomal recessive polycystic renal disease, ARPKD, and that is the genetic form, which is, as it said, autosomal recessive, so you need 2 copies of the abnormal gene to have the condition. And this is a condition that the kidneys will look abnormal from birth. So in this top picture, this is an example of a ARPKD kidney. So what you get is an enlarged echogenic kidney with loss of corticomedullary differentiation. And what you get are multiple tiny cysts, and often the cysts are too small for us to be able to characterize fully on ultrasound. And that's what sets it apart from the other cystic pathologies that we see. And then it's bilateral, so both kidneys are affected, which sets it apart from the multicystic dysplastic kidney, which is often unilateral, but can be occasionally bilateral. And then autosomal dominant polycystic kidney disease, that is also a genetic form, and that is, as it says in the name, you only need 1 copy of the gene. And the kidneys can look normal at birth, so they can have completely normal appearances. And then as the child grows up, they develop multiple cysts in the kidney. And this is commonly seen in older children and in adult patients, but we can see it from quite a young age in pediatrics. And you can see here where you've got multiple cysts within the kidney, but you do have some normal renal parenchyma in between the cysts, and that's how you differentiate between the 2. So this is just another case. I'll just talk you through this case rather than asking you. So here we've got a normal right-sided kidney, and on the left we've got echogenic parenchyma with loss of the corticomedullary differentiation, and then we've got multiple cysts in the kidney of different sizes. So this would be in keeping with a multicystic dysplastic kidney. If you saw that they had some dilatation, you may think it's due to obstructive uropathy as well. And then multicystic dysplastic kidneys can go on to have a DMSA study. So this is an example of that. So candidate 3, do you want to look at this DMSA study? What do you think?
Yeah. So I can appreciate there is a normal uptake in the right kidney, but the left kidney doesn't show any uptake of the contrast and no excretion.
Okay. And what about the split function?
Regarding the split function, I appreciate that there's definitely disproportionately negligible perfusion of the left kidney.
Mm-hmm.
And
Okay.
the ratio, so that is 6% split function, less than 10%. So it is again in support of a multicystic dysplastic kidney.
Exactly. So so this is a DMSA study. For those who may not have seen many DMSA studies, what they are is that they're a nuclear medicine study where you get uptake of technetium 99M labeled DMSA, and that's given via intravenous injection to the patient, and then it gets taken up by the kidneys, and it's a measure, and it's the best test to measure actual function of the kidney, so how much the kidney is contributing to the to the split function between the two kidneys. So in this case, as candidate 3 has said, you've got a normal functioning right kidney, and you can see that there's uptake of the DMSA within the right kidney. But then if you look at the left kidney, there's barely any uptake. And what it looks like is similar to the background. So this split function, it may not even be accurate because you may have some background measurements in there rather than the true function. But normally, split function in a DMSA study should be between 45 to 55%. So that's the range. So one kidney can be 45, the other 55, and anything in between that. Anything outside of that realm is abnormal. So if you have one kidney being 60%, one kidney being 40%, that's an abnormal. If you have one kidney being 93% in this case, then that shows that the other kidney is barely functioning. So multicystic dysplastic kidneys. So like I said, this is an antenatal process. It occurs in utero. Sorry, there's a typo here. It should say normally. It's sporadic or non-hereditary. So unlike the autosomal recessive, autosomal dominant polycystic kidney disease, there's no family history. And it's what happens where you get a replacement of the normal parenchyma with multiple disorganized cysts. And you can actually see the cysts within the kidney, as we saw in the previous case, rather than in an autosomal recessive polycystic kidney disease, where often the cysts are too small for you to fully identify them and be able to make measurements and things like that. It is normally unilateral because the bilateral is a really severe abnormality, and you get oligo or anhydromenous, and you get so that's a lack of or absence of fluid antenatally, and then this leads to inadequate lung development, and then they get perinatal death. So we don't often see kids being born and surviving the antenatal period if they've got bilateral multicystic dysplastic kidneys. Unilateral ones can be an isolated finding, but they can be associated with additional urogenital tract anomalies as well. So if you see one abnormal kidney, you have to look through to see if there's any other abnormalities you can pick up. And what happens over time is that the kidney can involute, so it basically just dies off. And if it's not picked up early, you might be scanning a 6-year-old, for example, and diagnosing them with unilateral renal agenesis, but it's actually because they've had an antenatal history of multicystic dysplastic kidney. So just to be aware that over time, the kidneys tend to involute, so it may disappear as you do follow-up imaging. Okay, so candidate 3, the next case.
I'm looking at the sedative images through the kidneys. So I can appreciate that there's a large cystic area at the upper pole of the right kidney, and on the left side, I appreciate the left kidney appears normal in appearance. And in the last images, these are axial through the bladder that nicely show that there is a large cystic lesion at the right with a uretaric junction with upstream dilatation of the distal ureter. And in retrospect, I also appreciate that there is dilatation of the pelvic ileal system on the right side. And especially the dilatation is most severe at the upper pole. So these are in keeping with the obstructive ureterocele on the right side, causing upper pole moiety obstruction, and also suggestive of a duplex right-sided calyceal system.
Yeah, so that's completely correct. So this is an example of a duplex kidney. So they're actually bilateral duplex kidneys. So on the right side, we've got dilatation of the pelvic ileal system, and this is actually the thinned upper moiety renal cortex here. So you can't see the upper pole very well on this image, upper moiety very well, but this is the thin cortex with dilatation of the collecting system and the proximal ureter. And then this is the lower moiety, which is not dilated. And then on the left side, this is your dividing column. So this can either be a prominent column of Bertin, but most likely we've got bilateral duplex kidneys here, or at least a bifid system on the left. And then as we look at the bladder, we can see that we've got this outpouching into the bladder with the upstream dilatation of the ureter. So this is in keeping with the urethrocoel in the context of duplex kidneys. So the patient then went on to have a micturating cystourethrogram study, which is a fluoroscopic study. So if you want to discuss these images, candidate 3.
Yeah. So I can appreciate the cystographic views demonstrate a filling defect on the right side, and the bladder morphology gradually fills up without any diverticulum on the later filled images, and there's no reflux appreciated in the last delayed images. So again, this supports the obstructive ureterocele that was seen on the ultrasound.
Okay. And why have we done the CUG study?
That was for the duplex system, because the low moiety reflexes in the upper obstructs. But
yeah, so that's completely correct. So because we've got an obstructing urethrocoel, the patient's gone on to have a MAG3 study, which is another nuclear medicine study. But this is with the isotope is taken up by the kidneys and the proximal renal tubules, if I remember correctly, and then it's excreted. So this is a functional assessment of the drainage of the kidneys. So are you able to look at this, candidate 3?
Yeah, sure. So I'm provided serial images of the MAG3 study, that is renal function. So first of all, I appreciate that there's a normally functioning left kidney with a rapid rise of the uptake, suggestive of perfusion, good perfusion, and then excretion that is also rapidly excreted. On the right side, on the images as well as in the graph, I appreciate there is a delayed uptake as well as excretion with a decreased slope. That is also evident in the split function, that is reduced on the right side, which is 43% against 57% on the left side. So this again demonstrates this obstructive cause of right side.
Okay, I'm just going to go through the interpretation of the MAG3 because I think you've got things a little bit confused. So this is looking at the uptake of the kidneys and then the excretion into the bladder over time. And then this is your static image representation of that. And then this is your graph that shows how they uptake and excrete. What I wanted you to point out is that you can see that there's uptake of the isotope in the left kidney, and then in the right kidney, there is uptake in the lower moiety, but you can see in the upper moiety, you're not getting much uptake. So if this was the DMSA study, which would look at the function, and you could do split functions for upper and lower moieties, that upper moiety probably wouldn't have much function because you're not seeing much uptake. But in terms of the kidneys and their excretion, you do have reduced uptake in the right kidney compared to the left, which is evidenced by your differential split function being out of range. So once again, 45 to 55 is your normal range, and this is slightly out. But you can see that both kidneys actually drain quite well. So there's no, the kidneys are draining pretty in a similar gradient, although there's just reduced uptake on the right kidney. It's just that upper moiety is not functioning very well, so that upper moiety is obstructed. But the lower moiety is draining pretty well. And normally we give frusemide, so that's the generic name for Lasix, because that just speeds up your test basically. But on this occasion they've not, but you've still got good drainage of the left and the left kidney and the lower moiety of the right kidney, despite not giving any frusemide. So duplex kidneys occur because of an incomplete fusion of the upper and lower moieties of the kidneys. So what you get is you get a prominent a rim of renal cortex, splitting the upper and lower moieties. So on ultrasound, sometimes we'll see a prominent column of Bertin, which is a rim of cortex, going to divide through the kidneys, and we have to decide whether we think this is a true duplex or anything in between, which is like a bifid system where the kidneys, which have a single collecting system, single pelvic cell system, or do they have separate pelvic cell systems and then have a single ureter? And unless you have dilatation, it can be really difficult to work out what's exactly going on with the kidneys. But if you do have a true duplex, where you've got two different renal pelvises and two separate ureters, both draining into the bladder, then what tends to happen is you can get an uncomplicated system where you have no dilatation, which we may not be able to then confidently identify as a true complete duplex on ultrasound. Or you can get a complicated system, and usually that is you get a dilated upper moiety, which you can see in our patient, and that's because you get a uretrocele at the insertion of the upper moiety ureter into the bladder. And often the upper moiety ureter can also be ectopically inserted. So it's not quite at the VUJ, or occasionally it can be inserted into the vagina in girls. And then these girls will present with constant dribbling and never being dry. So that's important if you get that clinical history to assess if they've got a duplex kidney. And then you'll get vesico-ureteric reflux into the lower moiety, as candidate 3 said. And then that's why we're going to do the MCUG study to look to see if there's any evidence of reflux. So this is an example of uncomplicated duplex kidneys and how difficult they can be to completely see on ultrasound. So the left kidney, I think, is easier to see here. We've got definite renal cortex coming down the middle, separating it into upper moiety and a lower moiety. But on the second image, on the right kidney, these are definitely duplex because I scanned them. It can be very difficult to see the differentiation, but this is the upper moiety here, and this is the lower moiety. So duplex kidneys I find challenging to diagnose if they're uncomplicated. So candidate 3, it's your turn again. Do you want to have a go at this case?
Okay, so again, I'm looking at the longitudinal image. These the markers on the right side. So the right kidney appears normal in this view, and in the next view on the left side, I appreciate there is marked dilatation of the renal pelvis up to the covered proximal ureter. And further, also on the left side, for the image, there's marked minuscule shaped abrupt shouldering of the pelvic ureteric junction. And on the axial image of the bladder, I appreciate it appears normal. So this appears to be a unilateral pelvic ureteric junction obstruction on the left side with thinning of the cortex, PUJ obstruction.
Okay. Go on. What would you do as your next step of investigation?
For further clarification, we can do, I'm confused, a nuclear medicine study.
Okay, so what question would you have if you see a PUJ obstruction? So this is a PUJ configuration, as candidate 3 said, because we've got dilatation of the pelvic cell system with an abrupt end at the pelvico-ureteric junction, and we don't see any distal ureteric dilatation when we're looking at images of the bladder. So this suggests that it's a proximal obstruction, PUJ configuration. So what question do we have when we see kidneys with a PUJ obstruction? What do we want to know?
Yeah, so we would like to do the cross-sectional imaging to know the causes, for example, for any obstructing vessels or bands.
Okay, so that's a potential thing. What about for nuclear medicine? What do we want to know from the nuclear medicine study?
So we can appreciate the function of the cortex and the split function.
And what else do we need to know?
I'm struggling, but
okay, no worries. So we need to also know whether if it's actually a true obstruction, so the kidney isn't draining, or whether it's just a dilated system with no obstruction. So we'll go on to do that. The best test to do that is a MAG3 study, because that gives you a bit of functional assessment, because you can look at the split function of the kidneys, and it also looks at the uptake and excretion of the radioisotope. So you can look to see if the kidney is obstructed or if it's just dilated but not obstructed. So we've got some images. So I'll show you the first set of images, which are the static images from the MAG3 study, and then I'll show you the curves afterwards. So this is going to be your left kidney here, and this is, your right kidney here, and this is your left kidney here. So if you just take a couple of seconds to look at that, and then I'll go on to the trace drawings. Okay, and then these are your curves. So what do you think? And your split function.
The initial images showed that there's persistent contrast retention in the left kidney.
Okay.
That's appreciable up till the delayed images, while on the right side there was normal uptake and then excretion of the contrast. Further on the trace as well, on the graph, the green is
the right kidney
and the red is the left.
Yes.
So the left kidney has persistent mild contrast retention and uptake without any visible excretion. And the bladder is conforming to the right renal excretion, that is gradual in uptake and has favorable downslope excretion. And the split function demonstrates that it's mainly the right kidney that is showing that is causing excretion or renal function 85%, 14% on the left side.
Okay, so you keep saying contrast, but just to be pedantic for nuclear medicine, it's tracer uptake or radioisotope. It's not contrast. So just be mindful of that in the exam when you're presenting nuclear medicine studies. You can say tracer uptake, but not contrast. And you're completely correct. So the numbers here are time. So these are over minutes, and you can see, as candidate 3 said, that you've got uptake and excretion in the right kidney over time, but the left kidney shows uptake, but just shows very sluggish excretion. So there is later on at about 53, 56 minutes that there has been some excretion of the radioisotope. But if we look at the graph, you can see that this is the right kidney, so it shows good radioisotope excretion and then good drainage. But then if you look at the left kidney, because of the reduced function, there's reduced uptake of the tracer. And then as we go to 19 minutes, as we saw in the static images, there's not really been any drainage of that kidney. But if they continued the graph on, as they did with the delayed, as they did with the static images, to about 53 minutes, 56 minutes, there would have eventually been some drainage of that kidney. So in my institution, we tend to do a delayed image after 30 minutes to see if there's been any drainage. Some places don't, but we tend to do that. And so if you had drawn that out, you'd have called it sluggish drainage rather than true obstruction. So pelvico-ureteric junction obstruction, PUJO, is due to dilatation of the renal pelvis and the calyces only. So you don't see any ureteric dilatation proximally or distally. And it can be a partial obstruction, so incomplete, or it can be a complete obstruction. And there are lots of different causes. So it can be it's hypothesized that the intrinsic cause is due to possibly abnormal smooth muscle at the pelvico-ureteric junction, which then causes an aperistaltic segment, so you don't get any drainage through that segment. Or it can be caused potentially by scarring, so in utero UTIs or things like that, or inflammatory abnormalities at the PUJO. As candidate 3 said, you can get occasionally extrinsic compression. So that's called a crossing vessel. So a vessel goes along the PUJO and then causes obstruction at that point. And that's diagnosed using MRA, but that tends to be done in older children. Or you can have an extrinsic compression due to an abdominal mass. So just be aware that when you're doing the ultrasound, try and look to see if there's any abdominal mass. You can try and look for a crossing vessel on ultrasound, but I find it very difficult. So MRI is the best option. And then what happens is, because you've got obstruction at the level of the PUJ, you then get back pressure into the kidney because the kidney is pushing against this obstruction, and then you'll get changes in the kidney. So you'll get cortical thinning, it will get stretched by the dilatation, but you'll also get damage to the cortex, which will make it appear more echogenic, and then you can go on to get obstructive uropathy and cystic renal disease secondary to the obstruction. In a child that's under 18 months old, they tend to try and manage it conservatively because it can be self-limiting and it can burn out and they don't quite know what the pathophysiology that causes it to resolve, but they'll tend to do serial ultrasounds and MAG3 studies if the ultrasounds show increasing dilatation to assess the function. The function, normally they don't intervene. Sorry, I've gone to, unless the function shows that there's less than 40% function in the affected kidney, they won't tend to intervene in the UK. But they'll monitor that function over time. And for surgical management, they tend to do a pyeloplasty, which is where they refashion the pelvico-ureteric junction to relieve the obstruction. But if they are planning to do surgery, if they're concerned about crossing vessel, we'll do an MRI first to make sure that there's no crossing vessel because they might need to reimplant that vessel as well. Other reasons that they might do surgery, apart from a drop in the renal function, are if there is evidence of cortical damage. So that shows that the kidney can't cope with the obstruction, or if the child has recurrent UTIs because they've got stasis of the urine within the collecting system, or if the child is symptomatic, such as having pain, they might consider surgery as well. So candidate 3, this is another case for you. So I'll give you a history of recurrent UTIs for this patient.
Okay, I provided multiple images of micturating cystourethrogram. I can appreciate in the first image that there is mildly irregular outline of the bladder. Otherwise, there is grade 5 reflux appreciated on both sides on the serial next image, where the ballooning of the calyces more on the left side and blunting of the papillary impressions. Further, I appreciate on the delayed image in the AP view, the posterior urethra appears markedly dilated, resembling a bullet nose shape. So my probable diagnosis is posterior urethral valve with bilateral vesico-ureteric refluxes.
So, sorry, just describe what makes you think it was posterior urethral valves again?
In the AP view, in the last, that appears to be a abrupt narrowing of the posterior urethra in a shouldering fashion, like a bullet nose.
Okay, but what about on the lateral view?
The lateral view appears normal. That doesn't show any abnormality.
Yeah. So I think Sam, jump in if you disagree, but I tend to make my diagnosis of posterior urethral valves primarily on the lateral view, and I think the appearances on the lateral view are normal. The AP view might be just because we're catching it as the child is passing urine, because you can see that the catheter is still in. But I don't think it's a case of posterior urethral valves. What's the word? The urethra, the posterior urethra looks normal on the lateral view.
I agree.
Okay. So knowing that the posterior urethra is normal, what do you now think is the diagnosis? Candidate 3.
So bilateral vesico-ureteric reflux, and that's the definite abnormality, but the cause for this abnormality, if I can view any cause of neurogenic bladder or obstructive cause.
Okay, does the bladder look abnormal?
Yeah, that looks abnormal. That looks like a irregular trabeculated appearance with small.
So you have to remember that the child is probably, this is a dynamic study. So if you look on the lateral where the bladder's relatively okay distended, what do you think there?
So again, this can be then isolated abnormality of the bilateral vesico-ureteric reflux.
Yeah. So this is a case of vesico-ureteric reflux, and it's a high-grade reflux. You can see that you've got marked dilatation of the ureters bilaterally, which extends into the renal pelvis. You've got clubbing of your calyces, so you can't definitely make out the papillary impressions, and the calyces look blunted. So this is high-grade, probably grade 4 or 5 vesico-ureteric reflux. I think on here, the bladder does look a little bit irregular, and I see what you mean, but I think it's also because it's dynamic and the child is probably passing urine as they're imaging. But when the bladder is nicely distended, there's no obvious trabeculations or diverticular or urethroceles to suggest a distal obstruction. So vesico-ureteric reflux, this is a risk factor for urinary tract infections, and in the UK, in children under the age of 1, we will tend to do an MCUG study to look for vesico-ureteric reflux. We will then do it in selective cases over the age of 1, depending on whether it's atypical infection or recurrent infections, etc., or if there's a family history of reflux and what the ultrasound shows. We can also see it rather than just an isolated de novo finding. We can see it in association with posterior urethral valves, and as I explained earlier, with duplex kidneys. In the UK, micturating cystourethrogram, so fluoroscopic study with injection of contrast into the bladder, either hand injected or under gravity, and watching for reflux into the ureters and renal pelvis during filling and emptying of the bladder is the gold standard. Some centres, particularly in the US and Europe, are moving towards doing ultrasound using SonoView as the contrast medium and doing the cystourethrogram via ultrasound. So in the UK, and in my practice, we tend to do it in children under 12 months. We will catheterize them ourselves within the radiology department. Over 12 months, they'll normally need a catheter inserted by the urology team, either under GA or sedation or with Entonox, depending on how your centre does it. And in older children, where they don't want to do such an invasive test, we can do an indirect MCUG, which is used in nuclear medicine, and they're normally done done in combination with the MAG3 studies that we discussed earlier. So once the tracer is drained into the bladder, they will then see if there's any evidence of reflux back into the ureters on the indirect MCUG. So depending on the grade, so there's 5 grades for VUR. I tend to remember them in quite a simple way. So grade 1 is where it's just into the ureter, as you can see here. Grade 2 is where it extends all the way into the renal pelvis, but there's no dilatation. And then I remember grade 3, 4, and 5 as mild, moderate, and severe. So dilatation. So grade 3, you've got mild dilatation, but you can still see the papillary impressions at your calyces, and the calyces appear sharp and not blunted. Grade 2, you're getting blunting of your calyces, as you can see here, but you're still getting the papillary impressions between the calyces. And then that was grade 4, and then grade 5 is where you get blunting of the calyces and you get loss of your papillary impression, so it looks like a really dilated, baggy collecting system. And depending on the grade, you can either manage it conservatively, so the lower the grade, the more conservatively managed that the patient is, or they can have a deflux procedure, which is where they inject material into the VUJ to try and make it smaller and reduce the risk of reflux. And if that fails and the child continues to have urinary tract infections, for example, then they'll do reimplantation of the ureter at the VUJ. And the higher grades tend to be what gets operated on. So this is an example of an indirect cystogram. So we've got evidence of, we've got a left and right kidney here, and you can see that, so the green is the bladder, so the child is passing urine and the bladder's emptying. And then these are traces to see how much isotope is in the kidneys. So you can see that stays generally steady. But then if you look at the ureters, so the left ureter is the blue line, you can see that as the bladder empties, you get an increase in isotope in the left ureter, which shows us that there is reflux. So here we see the left kidney, and here you can see this column of radioisotope as the bladder is emptying. So you can see the isotope within the bladder is reduced, and that shows you that there's reflux into that left kidney. So this is just an example of an indirect cystogram. So this can only be performed in a child that is toilet trained. So if a child is not able to wee on command, you can't perform this. So it tends to be done in older children as a less invasive way of looking for reflux. So I'm going to give you 2 more cases, candidate 3, and then we're going to switch over and hopefully we'll get through all the cases. So this is your next case. This is a 15-year-old girl presenting with right-sided flank pain.
Okay, sure. So at the longitudinal image of the right kidney, I can appreciate that there's a fairly normal vascularity, and in the prone images, I can appreciate that there is echogenic shadowing calculus in the covered proximal ureter. And in the transverse view, I appreciate there's mild dilatation. And in the last view, I appreciate this is of bladder, of left kidney, left kidney in prone position. So that's a markedly thinned out cortex with the grossly I can't make out the kidney well, but I can appreciate there is a shadowing calculus in the within the large fluid-filled cystic area replacing the kidney outline. So that appears to be bilateral obstructive uropathy with calculi.
Yeah, I'm sorry, my terrible left kidney image has tricked you. This is just lots of shallowing from ribs, and we're not getting a great image of the left kidney. There's no dilatation on the left.
Okay.
Sorry, it tricked you a little bit. But the right side, you're completely correct. So this is a dilated right kidney. So that this is all the calyces on the right kidney, and then you can see that we've got here, this is the right kidney prone, and this is the proximal ureter, and there's evidence of calculus in the proximal ureter. And then this is the left kidney, which isn't dilated, just a terrible image. And here we've got two echogenic foci with posterior acoustic shadowing in keeping with calculi, again seen in the left kidney. So we've got bilateral renal calculi. So I just included this case because often people don't consider renal calculi in pediatric patients, but there's actually an increase in prevalence being seen in pediatric patients. And it's thought that that's potentially due to lifestyle changes. So people are not staying as well hydrated, children are consuming more meat and things like that, which is putting them at risk of increasing calculi. So just be aware that abdo pain and vomiting in a child can be due to renal calculi as well. So most causes are thought to be, depending on the type of stone, so if it's UTI related, then they tend to get struvite stones, but you can also get metabolic causes such as hypercalciuria, hyperoxaluria, and cystinuria. So depending on the stone makeup, you can try and work out what you think is behind the renal calculi. There's also a high incidence of renal calculi in premature neonates than term neonates, and they think that's due to immaturity of the kidneys and immature function, or the medications that they're being given, leading to increased renal calculi. So an ultrasound, so in children, ultrasound is the first line imaging. We normally can find the calculi on ultrasound. So what you're looking for is, as we saw in our case, hyperechoic foci with posterior acoustic shadowing. If you put your color Doppler on, you get this thing called a twinkle artifact, where the color Doppler goes like red, shows you like a yellowy green twinkle, and red and blue, so it changes colors because of the calcification. And then you also need to look for features of obstruction. We rarely ever need to do a non-contrast CT-KUB in pediatric patients because we can often see where the stone is obstructing, but sometimes the mid-ureter we don't see very well in children. So if we have a dilated kidney, we see evidence of renal calculi, or there's a strong suspicion of renal calculi, but we can't see the obstructing stone, we will then go on to do a KUB to look for that one. If we can't see it proximally or distally, it's probably in the mid-ureter, so we need to find it. Also, sometimes we can't assess the full stone burden on ultrasound. We will then go on to do a CT-KUB. And because we're trying to minimize radiation, we'll tend to do a low-dose CT-KUB, particularly focusing just on the kidneys rather than including the pelvis, so we can minimize the radiation dose to the pelvic organs. So this, I think, will be your last case, candidate 3. So this is a pediatric patient with an antenatal diagnosis of bilateral hydronephrosis, who then goes on to have a postnatal ultrasound that shows bilateral hydronephrosis in a male patient. So we go on to do an MCUG. So what do you see?
Yeah, I'm provided a spot lateral film of the MCUG. I can appreciate that the posterior urethra is markedly dilated with the bullet nose appearance, abrupt narrowing at the prostatomembranous junction. Along with that, I can appreciate that the bladder shows trabeculated surface margins, and I also appreciate that there is reflux, partly covered reflux or diverticulum. If I can see the other images as well.
There's no more images, unfortunately. This is your one image.
The contrast field outpoaching adjacent to the dome of the bladder, that can be diverticulum, or it can be image of the partly imaged ureter, but more likely it could be a diverticulum. So my diagnosis is a posterior urethral valve with a trabeculated bladder and a bladder diverticulum.
Yeah, this was very good. Well done. This is a case of posterior urethral valves. If it was going to be a dilated ureter, you tend to see them coming posterior to the bladder on the lateral view, rather than starting at the dome of the bladder, just to help you differentiate between reflux and diverticulum. And these look very rounded to be refluxing ureters. So you're completely correct. This is the case of posterior urethral valves with evidence of bladder outlet obstruction, because you can see trabeculation of the bladder and diverticulum. So I just wanted to show you what a normal urethra should look like, so that you guys can get it into your minds, so that when you're presented with an abnormal one, you know what you're looking at. So this is an AP and a lateral view. So the urinary catheter is out on both views. And you can see on the AP, you should have no caliber change within the urinary bladder. And you should have a smooth bladder outline with no evidence of diverticulum. And then on the lateral view, we've got various parts that we see on the lateral view. So this is the wall of the bladder, which should be smooth, as I've said. This is the bladder neck. So there would normally be a caliber change between the posterior urethra and the at the bladder neck, because that's just a part of normal anatomy. And then this is the posterior urethra, also known as the prostatic urethra. And then the anterior urethra is made up of the membranous urethra and the bulbous urethra. So that is a normal study. Whereas if we go back to our previous one, you can see there's dilatation of that posterior urethra with an abrupt caliber change to the anterior urethra. So this is in keeping with posterior urethral valves. So this is a condition that affects males only, and it tends to be diagnosed, it tends to occur quite early on in the first trimester in utero, and then on the antenatal scans, they will present with bilateral pelvic ileal dilatation and ureteric dilatation. This is due to having a membranous valve at the level of the posterior or prostatic urethra, and that extends from the verumontanum to the distal portion of the urethra, as we can see in this image. So this is your membranous valve here. And there are three types. I'm not going to go into all three types, because type 1 is the most common, and that's where you get a valve which you have two folds which go anterior inferiorly. So here we go, so it's coming anterior inferiorly, and then they fuse at the anterior portion, but there's two portions to the valve. And then because of the valve causing outlet obstruction, you get back pressure, you get dilatation of the pelvic ileal system in the ureters, which become quite tortuous. And then you also get features of bladder outlet obstruction. So you get a thick-walled, trabeculated bladder with diverticulum, because that muscle is becoming hypertrophic, and because it's pushing against the resistance. And then because of the back pressure, you can get renal damage, as we saw as you can see with other causes of obstruction. So you can get cystic parenchymal changes as well. And then you can also get reflux into the kidneys because of the back pressure. One thing to be mindful of is when you're doing an ultrasound in these patients, they can have decompressed ureters and collecting systems if they've had a perforation, and then they get a urinoma. So the urine's found another way out of the kidney. So they can have decompression. So if you see a urinoma in a kid with antenatal diagnosis of bilateral hydronephrosis, still think posterior urethral valves as a possible cause. And these are managed surgically with ablations. This is just another example to show you the ultrasound findings. So here we've got a dilated collecting system with tortuous ureters that have been incompletely imaged. This is a bladder that's got a catheter in, so the bladder is completely empty, so we can't make a judgment on whether it's thick-walled, but here we can see dilated distal ureters. And then this is the ultrasound that shows that you've got that classic abrupt caliber change between the posterior and anterior urethra, and then you've got a trabeculated bladder wall. So this is posterior urethral valves. So I'm going to switch to candidate 4, because candidate 3, you've done a great job, but you must be getting quite tired. And we've only got a few more cases to go through, and hopefully we will finish on time. So candidate 4, are you ready?
Yes, doctor.
Okay. So do you want to have a go? This is a child that has had penile swelling and has had an ultrasound that shows abnormalities of the urethra. They've done a perineal ultrasound. So what do you think of this MCUG?
This MCUG is showing that there is a narrowing at the posterior urethra, the prostatic and membranous portion. This could be due to an infectious sequelae.
Okay. And what do you think about the anterior urethra? What do you think about this?
There is an outpouching from the inferior aspect.
So does that change your diagnosis? What do you think this outpouching could represent?
It could be due to some trauma, if there was history of trauma.
Okay, no history of trauma.
Could be a congenital diverticulum urethral diverticulum.
Yeah, that's correct. So this is, I think what's happened is we've caught it, the stream not very well on these images, which has led you to think that there's an abnormality, like a stricture here between the prostatic and membranous urethra, but the actual abnormality is here. So you've got a congenital urethral diverticulum in this patient, and that's the main finding. It's not something we see commonly in pediatrics. I've never seen it. This is actually a case that Sam kindly provided me. So this is an MRI which shows what we've seen on the MCG basically. So this is the penis here, and then we've got the urethra, and then you see this little fluid-filled structure here is your urethral diverticulum, just here, just to finalize the image. So urethral diverticulums are a congenital abnormality in pediatric patients. You can see them in adult patients, but they tend not to be congenital, and they tend to be more common in females in adult patients. But we're going to focus on the pediatric diagnosis, which tends to be in males and not females. And this is where you get a focal outpouching of the urethra, and it's normally at the mid portion of the anterior urethra, and it communicates with the lumen. So it involves so you'll get fluid, you'll get contrast opacifying the diverticulum as it goes through the lumen because there's a communication. It can cause outlet obstruction, so patients can present with bladder dysfunction as they're presenting this symptom, but often they present with, if it's not diagnosed early on in the neonatal period, then if they present later, they often present with penile swelling because they get the filling of the diverticulum. They can get recurrent UTIs because you've got stasis of urine within that diverticulum, and they can also have dribbling because the diverticulum then empties through the urethra, through the lumen, continuously after the child has finished passing urine. So this should say it can be associated with anterior urethral valves. And if there is an anterior urethral valve, so like in this diagram here, you can see there's a valve similar to a posterior urethral valve, then that child will present with antenatal hydroureteral nephrosis rather than it presenting in an older child. Okay, this is your next case. This is a MCUG. So this child has an anorectal malformation. That's their past history.
This is an MCUG image of a patient with an anorectal malformation. See that the contrast is filling within the urinary bladder. The bladder, there is no abnormalities of the bladder. However, I also see that there is contrast or opacification of the bowel, of the adjacent bowel lobes at the same time. So there could be a communication with urovesical fistula.
Okay, so where do you think we're injecting the contrast into, the bladder or the bowel on these images?
The tube is going into the bowel. Yes, I think it's bowel.
Okay, so what we've done on these images is something called a distal leukogram. So with the anorectal malformation children, what happens is that they get defunctioned because they don't have a way to pass their feces. So they get defunctioned and they get a stoma made, and then they have a distal mucus fistula, which is normally, for the ARNs, it's normally quite low in the region of the rectum or the sigmoid colon. And what we've done here is we've put the catheter through into that distal part of the defunctioned bowel, and we're injecting contrast through. And the reason the bladder is being opacified at the same time is because, as candidate 4 said, we've got a colovesical fistula. So if you look, this is the rectum here that's been opacified with contrast. And then if you look here, there's a connection between the urethra and the rectum. So this is your fistula. So it's actually a colourethral fistula rather than a colovesical fistula. But this is your connection here. So it's just going into the posterior urethra. So they need to know this. It's important that they know it for surgery, because when they go to repair the anorectal malformation and pull the rectum down and create the anal opening, they need to be able to disconnect the fistula and basically close the fistula so that they don't get fecal matter going into the bladder, because that will put the child at risk of infection, and that's not a normal connection that you should have. So colovesical fistulas are seen in patients with a history of anorectal malformation, and anorectal malformations can be associated with lots of other abnormalities. So if any of you were at the talk 2 weeks ago, we can see it, you'll remember esophageal atresia. Patients can have, as part of the Bacterel spectrum of findings, they can have anorectal malformations, which is the A in Bacterel, and it can be associated with lots of different malformations. And as I said, the surgeons will diagnose the anorectal malformation clinically, or the neonatal team will diagnose it clinically, and then they will then defunction them. And before they do the repair, they'll have in the UK at least, they'll have a micturating cystourethrogram and a contrast enema of that distal portion at the same time. And the 3 questions we're answering when we do this study is there a fistula? So is there an abnormal connection between the bladder and the bowel, or the urethra and the bowel? The position of the rectum and the gap to the perineum, because they need to know all of this to do their repair. Because they can be associated with lots of different abnormalities, the child will also have a renal and a spinal ultrasound. And this is just to show you the range of cloacal malformations and fistulae that we can see. So it can be different between male and female patients. So female patients can have just some narrowing of the anus, or they can get an imperforate anus, but no fistula formation. Or they can have a fistula with a colovesical fistula with the bladder or the urethra. But they can also get cloacal malformations where they get a single channel draining the bladder, the vagina, and the rectum. So the spectrum of abnormalities is greater in a female patient than it is in a male patient. In male patients, what we tend to see is the same stenoses or imperforate anus or anorectal malformations, but then they can also get fistulas to the bladder, to the urethra, to the scrotum, but they don't tend to get that single channel development. And then in terms of management, they have surgery. So like I said, initially they have a decompression, and then they'll have a repair where the fistula is repaired and the rectum is, if it's a true malformation, the rectum will be brought down to the perineum, and a neo-anus will be made. So this is just another example to show you. So this one, the child has had an MCUG first. So this is the bladder here that's been filled with contrast, and then you can see that we're pacifying the rectum when we're filling the bladder with contrast, and there's a connection here with the bladder base. And then we've done the distal leukogram, and although we can't see to look at the rest of the things, such as the distance from the perineum, so this is our marker on the perineum to show the gap, but although we can't see the connection when we do the distal leukogram, we are seeing that the bladder and the rectum are beaking towards each other, suggesting that there is a fistulous connection there. And then this is just another example because it's quite pretty when you can find the connection. So we'd like to take lots of images. So here we go. Here's another rectal pouch, contrast going through into the distal mucus fistula. And here's your connection between the posterior urethra and the rectum. So candidate 4, this is your next case. This is let's make them 7-year-old presenting with testicular pain.
These are the sagittal ultrasound images of a 7-year-old patient with testicular pain. The bilateral testes at baseline appear normal in size and echogenicity. The left testis is showing decreased vascularity compared to the right. 2 hours later, I see that there is progressive heterogeneity of one of the testes. I think this probably is the abnormal one on the left side with some hypoechoic areas. I would like to check for color Doppler interrogation, as this could represent torsion if the patient is having a history of trauma.
Okay. There's no history of trauma. It's atraumatic testicular pain.
If it was a sudden pain, this could be torsion.
Yeah. So this is a case of testicular torsion. The 2 hours later image I'll come back to in a second. But what we've got, so this should be your nice comparison view. And you can see that you've got color flow within your right testicle, but then within your left testicle, there's absence of flow. So there's absence of color flow, suggesting that there's no perfusion of that testicle, which can be the early sign of testicular torsion before you get any of the heterogeneity. And then I'll come back to this image in a second. So testicular torsion is, in the UK, we say it's a clinical diagnosis, not a radiological diagnosis. So if there's a high suspicion for testicular torsion, then they should proceed to have surgery rather than ultrasound, because ultrasound is just delaying it and time is precious if you think you've got a torted testicle. But if they do go to have an ultrasound, then they can have things you may see as an abnormal testicular lie. The affected testicle may be enlarged compared to the other testicle, and that's why I always start with a comparison view with both testicles in my field of view and ultrasound, so I can look to see if one looks different than the other. You can also see altered, so reduced or absent flow within the testicle, and the absence of flow is very important in testicular torsion. If you don't see any flow, then you have to suggest it's torsion until proven otherwise. And then you can also sometimes see a twist in the vessels within the somatic cord, giving you this whirlpool sign that you see with volvulus and things like that. So what this image was showing, so this is an example of a pseudomass here. So this is the testicle here, and then this is above the testicle, and this is what we call a pseudomass. So this can be what you can see if there's a delayed presentation, or you're scanning the patient a few hours after the testicle is torted, and this is where you're getting abnormality of the spermatic cord vessels, which is the twisted cord sat above the testicle. So it's called a pseudomass sign. And often you'll get an enlarged or displaced epididymis because you get reactive changes in the epididymis secondary to the torsion. So this is another example. So this is a patient that presented 2 days. I think this was a neonate that presented. Mum noticed that the testicle on the left side was becoming swollen and edematous, and she brought him to hospital after about 48 hours because it wasn't improving. And the ultrasound can show, so this is a normal right testicle here, and then this is the left testicle. You can see that you've got a really heterogeneous testicle with areas of hypoechogenicity and increased echogenicity. We've got edema of the scrotal soft tissues on the left hemiscrotum. We've got an absence of flow here, and then here we've got a hydrocele with some echoes within it, within that left testicle. So this is a case of a missed or delayed presentation where you've got a necrotic testicle. What was I going to say? So for missed torsions or late findings, let me just go back. You can see that the necrosis is the hypoechoic areas within the testicle. That implies necrosis. And then you can get some hyperechoic areas because of hemorrhage. So if the testes has managed to reperfuse itself, you'll get hemorrhagic infarction of of those areas, and then they can be hyperechogenic. So candidate 4, this is your next case. And this is a patient presenting with testicular pain and swelling, a 15-year-old.
Okay, so this is a 15-year-old who's presented with testicular pain and swelling. I see that these are sagittal images of the scrotum and the left testicle. The left testicle appears, there appears to be increased vascularity around the left testicle.
Mm-hmm.
Which is having a cord-like appearance, twisted cord type. So this could be again torsion.
Okay, so with torsion, do you expect to see increased flow in the testicle or reduced or absent flow?
It should be absent flow.
Okay, so here we've got quite a lot of flow within the testicle. This is just showing that you've got lots of flow. So what do you think is within the within the left testicle, sorry? So this is the right testicle up here, this is the left testicle. So you can see it's hyperemic compared to the right side. So what do you think the diagnosis may be? And the testicle is enlarged. Go on.
Epididymolysis.
Yeah, exactly. So this is a case of epididymolysis. So what you can see is that this is the comparison view. The left testicle appears larger than the right. You've got a hydrocele with some echogenic debris or septation within it. You've got scrotal edema as well. But the crucial thing, so you could maybe think this is all torsion, but when you put your color flow on, you can see that there's increased flow in the testicle, which you shouldn't see in torsion. So this suggests, as candidate 4 said, it's epididymolysis. So epididymolysis tends to give you an enlarged edematous epididymis and testicle, and you can get them individually. You can get just epididymitis without the orchitis, and in the epididymis it tends to affect the tail more than the body, more than the head. So that's where it tends to start, in the tail. And you see hyperemia, and you can get reactive changes, as we saw in the last case, hydrocele and scrotal edema and inflammation. But early on, you may think it's torsion because the patient presents as if they're having torsion, so with scrotal pain and swelling, and you may not get the full hyperemia early on. You might just see an enlarged edematous testicle. So I think if you're in doubt and you're doing it clinically, you have to speak to the surgeons and say, this may be torsion, and then they have to decide clinically if it fits or not. Normally, we see epididymolysis in pediatric patients secondary to urinary tract infections, but in older children, teenagers consider sexually transmitted infections as a cause. So we'll go to the next case. So this is a 14-year-old patient presenting with, I'll make them 10-year-old patient presenting with swelling of the left testicle. What do you think, candidate 4?
Yeah, so this is a 7-year-old patient presenting with swelling of the left testicle.
Mm-hmm.
There is in the hemiscrotum, the testicle appears normal. However, within the scrotum, I see that there are there appears a hypoechoic area, anechoic area.
Mm-hmm.
This could be a hydrocele. A hernia, a congenital hernia, funicular hernia.
Okay. So when you're ultrasounding this, you can get above this complex area. So there's no evidence of it going into the abdominal cavity. It's just within the scrotum.
So it could be a congenital septated collection. Could be a hydrocele, a funicular hydrocele.
So it looks quite complex for a hydrocele. So you can see, I see what you mean, that there's areas of fluid within it, but all of this region here is solid. So this is the scrotal wall here, and this is all a solid component within this abnormality. And then when color flow is put on the solid component, there is flow within that solid component. So what would your concern be for this within the testicle? No history of trauma, clinically well, just complaining of swelling, and has a solid cystic area with flow in the solid components.
It could be condition, neoplasm, a malignancy.
Yeah. So this is a case of rhabdomyosarcoma in the scrotum. So it's quite a difficult case. The images may not. I tried to pick the best images. We'll go on to this MR because the patient went on to have an MRI. So here you can see this is the lesion here on MR within the right hemiscrotum. So this is T1 weighted imaging. So you can see you've got this complex lesion in the this is T2 weighted imaging. You've got this complex lesion within the scrotum, and then on the T1 fat sap pre and post contrast, you can see that there's enhancement within the solid components and within the wall of the lesion. And then if we come up to the abdomen, the patient also had a lymph node in the left paraortic region. So this was a case of rhabdomyosarcoma. So just think, sometimes we see extra testicular masses in the scrotum. So intratesticular masses are very rare in pediatric patients. Normally they occur in older patients in the second decade, and they're normally germ cell tumours, such as yolk sac tumours. So they will have raised beta-HCG or alpha-fetoprotein. Prepubertal patients who have testicular masses, intratesticular masses, they tend to be benign, such as teratomas, whereas the older children tend to present with the malignant masses. Non-malignant lesions that we can see in the testicle include epidermoid, and that gives you the classic onion ring appearance, where you get multiple concentric circles within the lesion. Malignancy within the testes is associated with cryptorchidism, Klinefelters, and family history. So any patient who has these risk factors, you have to be switched on to. And normally we see them as hypoechoic and homogeneous vascular lesions on ultrasound, but as they grow, they can become heterogeneous and appear solid cystic. So microlithiasis is where you get punctate foci of calcification within the testicle, and it's normally defined as having more than 5 foci of calcification as microlithiasis. And it's controversial if this needs follow-up. Some people have said it can be a precursor for malignancy, but generally in the UK, we don't tend to follow these patients up unless they have a risk factor for developing testicular malignancies. Extra testicular masses, so benign ones such as lipomas of the spermatic cord, simple cysts, or we can see some chronic inflammatory changes. But if they're solid, they're most likely malignant, and the most common malignancy we'll see is a rhabdomyosarcoma, normally the embryonal type, and that shows as a heterogeneous solid cystic mass with increased flow, as we saw in our case. And then I just wanted to show you that this patient had the mass removed and had chemotherapy, and then as part of their routine follow-up imaging done 2 years later, they were found to have a lesion at the inferior aspect of the left kidney, and then within about 3 months it had grown quite large, and it was found to be a metastatic deposit from their rhabdomyosarcoma. And if we consider the drainage of the left testicle, then that goes via the left testicular vein into the left renal vein, so you can get metastases in the paraortic region and in the left kidney. Whereas on the right side, the drainage doesn't involve the right renal vein, so you don't tend to get the right-sided renal metastases. Case 36, we've only got 2 more cases. I know we're running over slightly, so those of you who can stay, we've only got 2 more cases, and then we'll be finishing, and I'll do some questions at the end. So do you want to have a go at this case, starting with the abdominal radiograph?
This is an abdominal radiograph showing multiple dilated bowel loops in the central as well as peripheral abdomen. I'm looking for the cause. I can see that the pelvis, the lower pelvis is not very... Okay, there are some bowel loops seen in the left side scrotum and left inguinal region. So this could be inguinal hernia.
Are you saying you're seeing bowel loops on the left on the X-ray or on the ultrasound images?
On the X-ray, yeah. I think there's something seen, not too sure.
Yeah, I'm not convinced that there's any bowel loops seen clearly in this inguinal region. I would suggest that the right inguinal soft tissues look expanded compared to the left, but I don't think you're definitely seeing any loops of bowel projected over these regions. But we're worried about a bowel obstruction, and clinically they're able to palpate a mass in the inguinal region, so they go on to have an ultrasound. So this is the ultrasound images, and tell me what you see.
On the sagittal ultrasound of focused on the right inguinal region, I see that there's a herniation of bowel loops. The vascularity is preserved. There is no interloop fluid.
Mm-hmm.
This is a right inguinal hernia.
And what do you think about that right testicle, which is within the scrotum? What are we seeing on the color Doppler image?
There's no vascularity seen within the testicle.
Okay, so what does that suggest is happening?
There's compromise of the vascular supply through.
Yeah, because
at the inguinal canal.
Yeah, so you've got the herniating bowel loops into the inguinal canal, as you can see here, and that's causing compression of the spermatic cord and the vessels, and it's affecting flow into that right testicle. So, so this is a case of a right inguinal canal hernia causing proximal upstream bowel obstruction. So the patient went to theatre and had the hernia repaired, and then the testicle, once they had reduced the pressure from the hernia, was seen to be well perfused, so didn't need to have any intervention on the testicle. Okay. So inguinal hernias in pediatric patients are normally indirect hernias, and they're because of incomplete obliteration of the processus vaginalis, or AKA the canal of Nock in female patients. As expected, they're more frequent in premature patients because that obliteration hasn't occurred, and it's more commonly in the right than the left. I'm not sure why, and we see them more commonly in males over female patients. And what we can see is you can get herniation of the mentum, so you can just see echogenic fat within the inguinal hernia. We can see bowel loops, as we did in our case, or we can see testes or ovaries in the inguinal region, especially in the neonates. You can also get a herniation of the fallopian tube, and rarely, which I've never seen before, the uterus. It's important to see the full extent of the hernia because it can extend into the scrotum or labia. So if you have a child presenting with scrotal or labial swelling, consider could it be a hernia and ultrasound. And it's important to check flow in the herniated bowel because if it's non-reducible, if it's incarcerated, you can get ischemia within the bowel. And if you see any herniation of a gonadal organ, so testes or ovary, also check flow to assess if they're viable or not. And then it's important when you're doing the ultrasound to check the contralateral side, as that they can be bilateral and it can be quite subtle on the other side. I was going to say, if there are contents within the if there's herniated bowel or ovary or testes within the inguinal hernia, then it can make it harder for it to be reduced. So then these may go to surgery, basically. And if there's any features of strangulation, so where you get a absence of flow within the bowel or within the gonadal organ, then they definitely have to go to surgery. So this is just to show you a case that we had in I think she was a month-old neonate, and here she presented with a swelling in her inguinal region, and here we've got herniation of the right ovary. Here we can see some follicles into that inguinal canal via the canal of Nock that's not been obliterated. So this is just right ovary sat in that inguinal canal, and then this is her left ovary sat where it should be in her pelvis, and she went to theatre for a repair and reduction, and her ovary was viable. As we can see, there's colour flow within it on the ultrasound. So this is a final case. So this is just a case in ovarian torsion. The images aren't very great, so I won't make you present this. I just wanted to show you that this is what a torted ovary looks like. So here we've got a very peripherally located, enlarged ovary. So you can see it's measuring more than 4 centimeters in each dimension. And there's an absence of flow within that ovary in keeping with an ovarian torsion. So ovarian torsion is, again, a clinical diagnosis in the UK. So people should, if the clinicians are worried about it, they should take them to theatre and not be asking for an ultrasound. But if it's an atypical presentation or a delayed presentation, they may then ask us to ultrasound the patient. And the findings we tend to see are an enlarged ovary of more than 4 centimeters, which was in our case, and it can be hyperechoic. And the peripheral follicles are the key here. So they get really peripherally located follicles, and the ovary often is in an abnormal position. So in our patient's case, it was very peripheral, and you could actually feel the ovary under the skin in the pelvis. Loss of flow in the ovary is also important, similar to testicular torsion. If you get absence of flow, then that suggests that the vascular compromise. And also a high percentage of these patients will have a significant volume of free fluid in their pelvis. And also, as you're scanning over the ovary, the patient will normally be tender over it. So that's a clinical sign you can elicit when you're scanning. It's important to be mindful that presence of flow in the ovary does not exclude torsion, because the ovary has dual supply. So it has supply from the ovarian artery, which is a branch from the aorta, but also branches of the uterine artery also supply the ovary. So you may see flow because only one branch is compromised. So that's why ultrasound could not exclude ovarian torsion. Additionally, they can have intermittent torsion where they're torting and detorting. So we may catch them when they're detorting. So we may not pick up all the classic signs on ultrasound. There's an increased risk if there's an adnexal mass, such as a large ovarian cyst. So even if I have a patient who presents as a torsion, but the ovary looks as I would expect it, but there's a big, like a 5+ centimeter cyst on the ovary, I will then say there's a large cyst. This puts the ovary at risk of torsion, and there may be intermittent torsion, and then the clinical team have to decide whether they're going to take them to theatre or not. And ovarian torsion leads to infarction and causes necrosis and hemorrhage, like we saw in testicular torsion, and surgical management is the definitive management. So in summary, we've covered quite a lot there. It's a lot to take in, but we've looked at renal cystic disease and looking at differentiating multicystic dysplastic kidneys from obstructive uropathies, as well as autosomal recessive and dominant polycystic kidney disease. We've talked a bit about duplex kidneys and PUJ obstruction and other urological presentations such as posterior urethral valves and renal calculi. And in terms of testicular and GU presentations that we see in pediatric patients, it tends to be torsion, epididymolysis and masses, hernias, and we can sometimes see ovarian torsion, although I would like to remind you that torsion are clinical diagnoses and we should not be ultrasounding these patients unless they're atypical or delayed presentations. So thank you very much for listening. I'm just going to go back because I think I confused everybody with
Toby, I'm going to share because I've got another screen that I think shows it more clearly. So just let me bring it up.
Yeah, I'll stop sharing so you can share.
Again, share my screen.
So we're nearly done, guys.
Yeah. So Topes, can you see it?
Yes, here we go. Oh yeah, there we go. So I confused everyone and
clearer. So this is the original scan. Oh crap!
Thank you. So I got my rights and lefts confused. So apologies. So this is the PUJO case.
So there's a PUJO. There's the initial one. Yeah. And then this is the one that shows you just spot images, which is probably a lot easier to. Yeah.
So this is uptake in the normal right kidney, so the right side. So we normally do the AP.
Posterior.
So
PA.
Posterior. So the right is on the right of the screen and the left is on the left of the screen. So this is normal uptake and excretion in that right kidney. So you can see there's actually tracer going down the ureter into the bladder. And then this is delayed uptake into the left kidney. So you can see that you're not really getting uptake until about 15-20 minutes throughout that kidney with no excretion going into the bladder. So sorry for confusing everyone there. But that is clarification. So the left kidney was abnormal on that MAG3 study, which fit in with the curves that we were seeing. I just don't think there are any other questions. I think we've stunned you all into silence, or Sam has been great in answering the questions as we've been going through.
I think I have answered some of them. Hang on. So they all say, no more questions. All the others that have asked me directly, I have answered. Okay, guys, I don't know about you guys, I'm tired. So
so just put up the feedback slide once more.
Oh, yeah.
Remind everyone to give us some feedback. Thank you very much. Oh, yeah, sorry, there was a question about urethral treatment. The most common treatment is they get puncturing of the urethral, particularly if they're getting recurrent UTIs or that upper moiety has reduced function. So the urethral will get punctured. So they'll just basically break it apart. Sometimes they do leave them if they're not planning to intervene because the patient's asymptomatic or the upper moiety has already lost all its function and is not salvageable. They will just leave them. So sometimes you have older kids who still have a urethral, but generally they tend to puncture them. So yeah, that's it. So thank you very much, everyone. Well done again to all the candidates. You all did very well, and there were some tricky cases in there. Please give us some feedback, and we hopefully see you all next week at the final pediatric session, which is on cardiac and chest pathologies. Take care. Thank you very much for your attention. Bye.
Thank you. Bye.